Good afternoon. Thank you for joining the webinar. My name is Ms. Darcy Walsh, and I'm with the Council of State Governments Justice Center. Before turning the webinar over to today's presenters, I'd like to briefly talk through a couple of housekeeping items about how the webinar is going to work, and then take a brief moment to tell you a little bit about the National Reentry Resource Center. Anytime during this webinar, you can ask a question by typing it into the QA panel on the bottom right-hand portion of your screen. We will keep a running list of the content-related questions that we receive, and then ask the panelists to respond to the questions during the last segment of the webinar. We will do our best to get through as many questions as possible, but please understand that this is a very large webinar, so your question may not get answered. If we do not get to your question, we encourage you to email the presenters directly, and contact information for our presenters will be provided at the end of the presentation. If you encounter technical or audio problems during this webinar, please call WebEx Technical Support at 1-866-229-3239. Please understand that there are some technical issues you may not be able to resolve. For this reason, we are recording this event, and we will post it on our website at csgjusticecenter.org. We should have the webinar posted online early next week, and once it has been posted, we will email you a link to the recording. With those housekeeping items out of the way, let me tell you a little bit about the sponsors of this webinar. This webinar has been sponsored by the Criminal Justice Mental Health Consensus Project and the National Reentry Resource Center, with funding from the Bureau of Justice Assistance and the Office of Juvenile Justice and Delinquency Prevention. The Mental Health Consensus Project, coordinated by the Council of State Governments Justice Center, is an unprecedented national effort to help local, state, and federal policymakers and criminal justice and mental health professionals improve the response to people with mental illnesses who come into contact with the criminal justice system. The National Reentry Resource Center, established by the Second Chance Act and administered by the Bureau of Justice Assistance, U.S. Department of Justice, provides education, training, and technical assistance to states, tribes, territories, local government, service providers, nonprofit organizations, and corrections institutions working on prisoner reentry. It is a project of the Council of State Governments Justice Center with key project partners, including the Urban Institute, the Association of State Correctional Administrators, and the American Probation and Parole Association. The Center's overall mission is to advance the reentry field through knowledge transfer and dissemination and to promote evidence-based practices. This slide provides a snapshot of the Justice Center's homepage. We are constantly adding new content and resources to our website, and we send out a monthly newsletter that provides information about the latest research, funding opportunities, distance learning events, and other news about reentry. To sign up for the webinar, please visit csgjusticecenter.org after today's webinar. I'm now going to turn the webinar over to Shay Bilchik, who will be moderating the webinar today. Shay Bilchik is the founder and director of the Center for Juvenile Justice Reform at Georgetown University Public Policy Institute. He also serves as the chair of the National Reentry Resource Center's Juvenile Justice Committee and is a key advisor to the Council of State Governments Justice Center's juvenile justice work. Thank you all for participating in this panel today. Shay?
Thank you, Ms. Asya. It's great to be with you all. Love the fact that we got such a great response to this particular webinar announcement. As you know from the flyer, this is a two-part series. We did the first part, I should say, in 2012, and now this is a follow-up. That first webinar focused on identifying behavioral health needs and on the delivery of treatment while in placement. And this webinar focuses on the transition from placement to community and how community supervision and treatment providers can best support youth with behavioral health needs following release from out-of-home placement. So why is this so important? I think there's two goals we have for the young people who come into our care. One is to make sure they have the most productive experience possible, therapeutic experience possible while they are in care, and then making sure that is matched with a strong set of supports as they re-enter their community. In essence, a continuity of care that we're looking for. This requires agency staff in the facilities to be actively involved, not just while the youth is in care in their treatment plan, but also as the planning for reentry is unfolding. That requires that the community staff from the public agency who will be involved in that reentry effectively as part of a team with that agency or facility staff. That treatment providers those that are used while in care, and those that are going to be used in the community, form a bridge for that young person as they re-enter the community as well. All of this under an umbrella of effective family and youth engagement and community engagement or reentry planning around schools or vocational training, depending upon the particular plan for a child. In essence, this is a team or systemic approach that is necessary, and that was our goal for having these two different parts to the webinar, to paint a picture of what that would look like in terms of that continuity of care. It could not be achieved with individual pieces being thrown together. It requires a holistic approach, in essence, a therapeutic bridge back to the community with developmentally, therapeutically appropriate interventions for each child on an individual basis. So we think we put together a strong second part to our two-part webinar. We have a great set of presenters who will be with us today. And I want to introduce them to you first in mass and then turn it over to our first presenter to begin the webinar. Darren Carver, who will be our first presenter, has worked extensively over the past 20 years as a therapist, program developer, and consultant. His primary focus has been linking clinical research with the actual practice in practice settings. He currently serves as the clinical practice administrator for Weber Human Services in Utah. He's been actively involved in the development and diffusion of evidence-based practice through a variety of private and public entities, including Vanderbilt University, Georgetown University, and the University of Utah. His work in this area has brought national attention to the promise and challenges associated with bridging science and service. He's published professional articles on mental health, substance abuse, and juvenile justice-related topics. He earned his master's degree in clinical social work from the University of Utah in 1991. Darren will be followed by Kevin Shepard, who serves two roles for the Ohio Department of Youth Services. He's the Chief of Parole, which requires him to oversee the operations of 5 regional parole offices located throughout the state of Ohio. He also serves as the Chair of the Release Authority, which is the final and sole authority for making release and discharge decisions for youth committed to the legal custody of the Ohio Department of Youth Services. Kevin received his bachelor's degree in criminal justice from Kent State University and has designed a very innovative and effective reentry continuum being utilized in the state of Ohio. Eric Schaefer will be our third presenter. Eric has been involved in community corrections for the past 20 years and holds a master's degree in community counseling from the University of Dayton. He's held various positions during his tenure, including the Director of Probation Services, and is currently the Assistant Court Administrator for the Montgomery County Juvenile Court in Ohio. He has also worked in the field as a substance abuse counselor. And last but not least, Barbara Keene-Marsh, who is the Program Director of Outpatient Youth and Family Services at South Community Behavioral Health Care in Dayton, Ohio, will conclude our 4-presenter panel. Barbara's been involved in youth services for over 20 years. That seems to be a magical marker for our panel today, 20 years and more. Barbara has held various positions, which has included working in court and child welfare settings. She holds a master's degree in social work as a licensed independent social worker and an independently licensed chemical dependency counselor in the state of Ohio. Barbara has also been involved in a very innovative approach used in Ohio probably for almost the past 15 to 20 years, and now evolving statewide, something called behavioral health juvenile justice. So with that, I'm going to turn it over to our very able presenters, and we'll start with Darren Carver. Darren.
Thank you, Shay. Appreciate the opportunity to be with you, or at least participate with you in this webinar today. My role really is to discuss some of the basic tenets of reentry intervention, and the other panelists will talk, I think, a bit more specifically about some concepts and ideas of how this works. But these, I think, these tenets are essentially the foundation in which any good reentry system, particularly from a provider perspective, should be functioning. So the first concept, and of course this really has become the standard of practice, I think, in reentry programs, and that's family involvement, pre-transition, during the transition, and of course post-reentry. Parents often believe that the termination of the confinement period, whatever that may be, or the out-of-home placement period, is somehow an end of intervention date. They often present to us as ambivalent and at times even hostile about either the reasons for confinement or the reasons for having to continue to participate in some type of treatment. We felt like it's very important that counselors who are working with these families in that pre-transition period have a range of responses for parents who present potentially guarded, expressing intense negativity, or may even be passive about the problems themselves. So matching engagement strategies to that initial response of parents prior to the youth's release seems to increase the likelihood of a smooth transition. Contact also in that first 48 hours for us has been very important in our success in working with youth who are reentering the community. It's important to remember that family stress increases dramatically every time you add a member or take one away. Some youth reenter their home environment with a desire to really progress. Others return with some resentment and with the intention of re-engaging in some old behaviors pretty quickly. For these reasons, we stress the importance of an initial session within 48 hours of release and more frequent contact in the first 2 months post-release. Excuse me. I think it's important for caregivers and youth to leave that initial session that happens with really a firm sense that the counselor recognizes their strengths and especially the progress that was made during the time of the youth was out of home. We often make it explicit that these youth and their parents know the problems far better than we, and do our best to keep them in that expert role. Finally, creating these consistent expectations that family members stay involved is challenging, but still very important. We find that the poor disciplinary practices, poor structure and supervision, at times parental antisocial values, or even their own co-occurring disorders, keep that youth at risk for delinquency. So we try very hard to keep them engaged throughout that post-reentry time frame and to keep our expectations appropriate. We know that these families have had these challenges oftentimes for many years, and so we recognize their progress and try to maintain those appropriate expectations. I think the next basic tenet that is so important for programs serving youth who are reentering is to capitalize on the gains and focus on generalization of those gains for the youth. Sometimes providers are unfortunately a little quick to dismiss some of the progress made when the youth was either in a facility or in a different out-of-home setting. And they will mistakenly believe that progress was simply due to the fact that the youth was confined. Those providers really, in my opinion, miss an opportunity to create plans to help the youth generalize the gains from the confined setting to the community. Sometimes community-based providers also want to establish a treatment plan that does not incorporate those gains made, and we feel that's a significant mistake. There should be a concerted effort to try and generalize any behavioral health gains that were made during the confinement period or while the youth was out of home. And when it comes to establishing treatment plans, so important that there be very specific, that we be very specific about the roles that each person will play in removing barriers and maintaining current progress. This seems to increase the intention of the youth to follow through with some of the things that they were able to improve on while out of home. This next slide is a simple conceptualization of the concept of reentry treatment planning. You have the out-of-home identified objectives and the gains made that need to be moved into the current treatment plan. And below you have some community-based identified objectives that may be warranted based on the youth transitioning back into the home. It's a strength-based treatment plan that incorporates generalization of gains and is a blend of the confinement and community-based identified objectives. The next basic tenet that I want to speak to for just a moment is the idea of ongoing assessment. I think most people recognize that mental illness is a moving target during adolescence. And I have noticed in my work with counselors that as they stay involved with clients and families over extended period of time, they can at times miss the development or changing nature of a particular mental illness for youth. And even though these clinicians know the family well, they often need to be reminded to do additional assessment to be certain that we're targeting the right behavioral health problems. And finally, the concept of randomized drug testing really should be done for the vast majority of juveniles. We recognize that substance abuse and its effects on mental illness are well documented, and substance use must be a treatment target if it's detected. And finally, well, actually 2 more slides here, but another basic tenet is to prepare for and plan for the resurgence of symptoms or relapse. I think in an attempt to highlight some of the progress during confinement, what happens is that judges, probation officers, and families end up being provided a glowing report of progress during confinement. And while we do want to highlight the gains made, we see that that sometimes the court may not recognize that there is an uneven course, often consistent with mental illness and other behavioral health problems. So while we never want relapse or symptoms resurgence, it's important that we convey to the court that this often is more the norm and should be expected. Early, regular discussions about the reality of symptom relapse combined with the acquisition of well-defined coping strategies can go a long way to prevent a return to confinement. We have incorporated elements of the illness management recovery model simply because it has particularly well-developed coping strategies. And finally, we need to educate all involved about the chronic nature of mental illness and remember that recovery can mean different things to different youth, and sometimes maintenance is an acceptable outcome when it comes to some of these mental health challenges. And the final point I would like to speak to is the importance for providers to continue to focus on the risk factors for delinquency. This slide has 2 graphs, one representing the recidivism reduction of a program called Project Empower that we run here in Utah. Project Empower serves youth who, many of whom are coming back into the community, others who are just moved into this community-based treatment. You can see the 1-year recidivism difference between the comparison group and the Project Empower youth. These recidivism reductions are a result of the focus on the risk factors for delinquency and the use of evidence-based models that focus on recidivism reduction. The graph on the right shows the reductions in psychiatric symptoms and substance abuse symptoms and an overall picture based on the readministration of the drug use screening inventory. And what you can see here again are good solid reductions in the psychiatric problems youth present with and the substance abuse problems, as well as overall measures that coincide with the use of these evidence-based models. And so keeping your eye on those risk factors for delinquency and treating those is an important element of effective reentry programs. And with that, I will turn the time over to the next panelist. Thank you for your time today.
Kevin, you're up.
Well, thank you, Darren, and thank you, Shay, for the introduction earlier. My role here today is I'm going to try and explain and share with you some of the initiatives and the reentry continuum that we have implemented and honestly continue to implement here in the state of Ohio. So with the first couple of slides, I want to try and paint a picture for you for the population that we currently have in our state of Ohio juvenile facilities. But I think it's important to start that by saying as recently as 5 or 6 years ago, the population of youth we had in our facilities was in excess of 1,900 youth. And as of today, and for approximately the last year, we've kind of seemed to have leveled out right around the 500 number. So we've had a dramatic decrease in the number of youth who have been committed to our facilities. Now, what you see here in front of you on the slide shows that what we once thought were the outliers or the minorities, the mental health youth, have become the majority. We have on this is a snapshot of one particular day in the month of June, where the 54% of all youth in our facilities were on a mental health caseload, and that definition being that they were either being seen by a psychiatrist or a psychologist, and most likely were on some form of medication management. We also have 2 mental health units that can hold up to 35 people. On an average, we're having 26 youth on mental health units on any particular day, and those are obviously the most severe cases that we have committed to us. A great deal of our youth are in need of special education, and I'll talk about that just briefly in the next slide as well. You can see that the misnomer of youth services or Department of Youth Services is a little bit off. Our youth are actually 17.7 years of age on average, and they stay in our facility for about a year. When they're released on parole, they come out already adults, and I'll talk about that a little bit in later slide as well, and the particular issues that presents, especially as it relates to youth with mental health issues. This is just an expansion on the youth receiving special education. As you can see, of that 244 on the last slide, 150 of them were on receiving some form of special education, the great majority of them being some sort of emotional disturbance, which I'm sure you're all aware make it particularly difficult to work with these youth and to get them in a setting where they can be dealt with and treatment plans can be designed for them. This next slide talks about length of stay, and my attempt here is to show you that youth that are on the mental health caseload serve very similar times, actually a few days less than youth not on a mental health caseload. And the point here being that I want to stress that our department doesn't, we do not keep youth as a practice in our facilities just for the reasons of mental health issues. We do a really good job of transitioning youth and getting them out on the minimum date, the first opportunity that we have. Also, I wanted to mention here that as it relates to the type of offense, again, looks very similar, nothing statistically different. So as it is, the youth who come in on a mental health caseload, it really is comparing apples to apples with respect to length of stay and the type of offense they come in on. So what we've done here in Ohio with our Bureau of Parole is we have begun the process. We've changed the way our parole officers interact with families and with youth and with courts, with communities. We've tried to make them more of a change agent, if you will, as opposed to a compliance monitor. And in this role of a case manager, they begin working with the youth immediately upon commitment to DYS. Usually that happens, the case is assigned within the first 10 days. And they work with the youth all through their stay in the facility while also working with the family and also, obviously, once they're released to parole. We initiated what we call the EPICS model, which is a cognitive behavioral therapy model. Excuse me, my voice is leaving me. And that allows us to, it's a model based on the risk-need responsivity and allows us to identify unique needs of each youth. So we're able to work with youth on their individual needs. We target high-risk areas first and allows us to, address the issues in area of importance first. Based on the success of that, we actually expanded it to what we call family epics. And again, this is a cognitive behavioral therapy model. What our parole officers do is actually go into the homes of these families and work with them while the youth is incarcerated. We're in there trying to teach them skills that will be advantageous to them when youth return to their homes. As we all know, most families are not prepared when youth return to them. And this is our effort to empower them and to teach them new skills. For some of you, this may sound like, wow, where'd this come from? But I can tell you, the overwhelming response that we've gotten from our families has been extremely positive. For a lot of our mothers and grandmothers particularly, this is the first opportunity that anyone has ever maybe sat down with them and made the effort to show them that, this is what's going on with your youth in the facility, and when he returns to the community, we want to continue those efforts, and the reinforcement of the family is paramount in making that happen. At the same time, we've started a number of initiatives with our parole officers that happen both during incarceration and certainly after the youth are released on the parole. The first of them is the Juvenile Relational Inquiry Tool, which is a partnership we have with VERA in the state of New York. VERA, along with us and the state of Michigan and Arizona, created an 8-question assessment tool that allows our parole officers, either in the initial visit or an early visit with the youth, to find out who that youth thinks is important in their lives. They can then return to the community, find these folks, and identify them in ways where they can, create a support system for those youth. We all know that many times the families are not the most supportive group out there, so we're out trying to find other avenues where we can, create a group of people to be there and to have that youth be able to rely on somebody. We have also equipped all of our parole officers with laptop computers with video technology, which is a fantastic way for our folks to not only keep youth and family connected. We may have a youth in a facility 200 miles away from his home, so we can do video visits that way. But we've also have spread that into keeping the courts connected, keeping the community service agencies connected, especially with respect to behavioral health youth. Almost in all instances, youth were in some form of community service agency treatment upon entry, so we like to keep them involved while the youth is in our facility, and then the transition back to them upon return to the community is much easier. One of our more recent initiatives is the Community Linkage Partnership that we were able to create with another state agency here in Ohio, the Department of Mental Health. The Department of Mental Health has actually funded 3 positions that operate within our facilities, and any youth who is on a mental health caseload, the day he is approved for release, which typically is 60 or 90 days prior to his release, they begin the process of engaging the county behavioral health boards, getting back in touch with funding streams, and we try to create, a network of establishing, making sure this kid on the day he gets out, he has an appointment. We already have the doctor lined up. We send our youth out with 30 days of medication. Our Youth ID project is something we partnered with the State of Ohio Bureau of Motor Vehicles. And what we do is every youth who leaves our facility where we have a documented Social Security card and birth certificate, we give them an ID card that they can then exchange at the local BMV for a State of Ohio identification card. And this improves their effort to find employment, to get an apartment. If they can get into an apartment, turn on their utilities, for example, and we found it to be a big improvement in narrowing the service gap when a youth is released. Our Close to Home initiative is a free bus transportation project that we put together. And again, as I mentioned, we may have youth and families separated by many miles. What we've done is gone to the families and we'll put them on a bus and take them to see their loved one. I can tell you that in the first year we did this, we were able to transport over 750 family members and loved ones to see their youth. So again, it's a big effort by us to support family engagement and to keep the youth so he's not so doesn't have that feeling of despair that he's lost contact with where he's going back to. We've also are working on a discharge agreement. We've piloted several versions now, and we've kind of borrowed this from the child welfare systems. But our intent is to create a folder or a binder that is given to these youth upon their discharge from parole, and it includes things such as their medical records, such as their other health records. We make sure they have their birth certificate, their social security cards, things that are essential in their move forward, along with the support network that we have created. We've got to a point where we have it almost where in a contract basis where folks who have promised or have indicated that they would be a support, we include them with phone numbers, with addresses. That way, once a youth is out on his own or living with other folks, when he's in need, he has a resource to go to. We also include lists of all community service agencies in the community where he's living, any kind of emergency numbers, and we found this to be very beneficial for the initial steps that we have going forward. Our family finding technology is something we've trained all of our parole supervisors on, and if I had more time here today, I would love to tell you some stories about how we've had 3 youth who we've been able to reconnect to mothers who they were under the impression had been passed away. So what we've done is through internet searches, we can identify either long lost or removed family members and put them back in touch. This has been a very important piece for a lot of our kids who come up through the social or the family welfare networks and may have lost touch with families. So this has been a big improvement for us as well. Our reentry coalitions are local efforts in the communities to gather a lot of community service agencies together, and typically they meet either monthly or quarterly. They then we staff particular youth who may be returning to that community in the near term, and we're able to design plans for them for when they are released. And finally, our pre-qualified vendors initiative is a piece we put together for the great majority of our youth upon release are covered by Medicaid, and so upon release, they have the ability to receive services. The pre-qualified vendors initiative was put together for those youth who are not eligible for Medicaid and may not have insurance via their family. So we have established contracts with all 88 counties in the state of Ohio with community service agencies who are now able to, when a youth returns to that particular community, we can contact them and say, okay, there's a youth coming out on the 15th of next month. We want to go into a pay agreement with you, and the Department of Youth Services will actually pay for those services. I mentioned Medicaid briefly and want to touch on it in the sense that we've also been able to come to an agreement with our Medicaid group here in Ohio. One of the things that's always been interesting about youth when they're committed to our department is they're able to turn off their Medicaid services almost immediately. So we went back to them and had a long discussion and worked through a lot of avenues and channels and got a lot of important folks to the table to where now, upon release, if a youth has served less than 12 months with us, which is about what our average is, we can make a phone call and have Medicaid benefits reinstated that day. So you can imagine that on the day of release, we make a phone call. He has Medicaid benefits. He's then able to make sure that he has the ability to pay for services that we have him linked up to in the community. So again, a huge benefit for us. The final piece is coordinating the effort, and this has been a vital piece for us. As I've mentioned, I know I went through them quickly. As I mentioned, all these initiatives we have ongoing in our effort to keep behavioral health issues at the forefront when a youth is not only with us, but especially upon return to the community. We have all these folks coming into our facilities, so we knew we had to create capacity with our institutions and sit down with them and develop a plan for being able to get these folks in and out of the facilities. You know, being able to schedule times to do video conferences and set that kind of thing up. We had a tremendous response from our facilities, and I'm very proud and happy to say that it went extremely well, and the interaction back and forth is probably better than it's ever been. I quickly want to touch on our interdisciplinary teams. These are monthly meetings that take place in the facility, and the social worker gets folks from all disciplines. It's akin to a treatment team for each youth. So we are then, after every month when those IDTs are complete, notes are taken and entered into a system which we can then share with the court, with community service agencies, and keep everyone up to date and involved. Our parole officers are doing a much better job of actually participating in these IDTs, either in person or via phone or via video conference. As I've mentioned several times, the family involvement piece has been huge for us, not only with the bus transportation, but we have our parole officers taking these family members back and forth to the facility to sit down and to see their youth and to remain involved with them. My role with the release authority involves panel reviews, which is essentially the parole board saying, yes, this youth is approved for release, or no, he's not. But we have asked that as many people as we can are involved with those panel reviews. We get folks from the community coming in. We get their therapist. We get the parole officer. We even have judges and courts participate in these reviews, and it's been a very positive experience, not only for the youth, but for the facility and for parole and for the department as a whole. So, as I said, the huge piece in this is taking our parole officers and making them the case manager and making them the person that coordinates this effort and keeps the discussion focused on behavioral health issues or whatever the issue might be if these kids aren't on a behavioral health caseload. But our parole officers have now become the bridge to the community and the community service agencies. I know you're going to hear from Barb Marsh and shortly, and she can tell you her relationship with South Community and how our parole officers have been able to keep those open lines of communication and better serve the youth upon their release. So I thank you for your time, and with that, I'm going to turn this over to Eric Schaefer.
Thank you, Kevin. Eric, before you start, I just want to remind people that we are saving time at the end of the webinar for questions, but that does not mean that you have to hold off on sending in your questions during the course of the webinar. So we have about 3 or 4 questions that have come in already. So feel free, we'll stack them up and we'll try to answer as many as we can before we adjourn at the 90-minute mark. So Eric, over to you.
Thank you very much. Big thanks to Kevin and to Shay for having us be a part of the webinar. My focus today is, I think, to give a local example of how we've been able to plan locally and get kids to treatment once they've finished an episode of out-of-home placement. But before I jump into some of that locally, I have to share a little bit about Ohio's Behavioral Health and Juvenile Justice Initiative. This initiative started back in 2005 from a request for proposal from Kevin's agency, the Department of Youth Services, as well as the Ohio Department of Mental Health. The goal was to try to bring evidence-based practice to Ohio in a more consistent way, as well as to try to serve kids that may be eligible for commitment to the Department of Youth Services and see if we can provide them treatment before that became an option. So in 2005, Montgomery County, Ohio, which is Dayton, Ohio, received one of these grants, and we were able to work closely with South Community Incorporated, which you're going to hear from Barb Marsh here in a little bit, to bring functional family therapy in and subject our families to that type of treatment. So we were real excited to be able to do that. And it was basically the first time we were able to bring a family-focused treatment modality to our community. And it was just the beginning. After that, things seemed to really take off. So to talk a little bit about our project, like I said, it's functional family therapy, and we have a fancy title of Learning Independence and Family Empowerment. We call it the LIFE Project. And this is a true partnership, I believe, between a court agency and a treatment provider. South Community is a community treatment provider in Montgomery County, and we put this proposal together as a partnership. We started with focus on young ladies and young ladies that had felonies of violence. So we had a very narrow scope to start. And today, many years later, we're serving boys and girls of all kinds. So that is a little bit about our project. What I want to do is talk about how we have developed, I believe, continuity in Montgomery County and developed pathways from a lot of our local out-of-home placements to South Community. And so that our families, once they're leaving that out-of-home placement, if it's a very viable home situation, we can bring in functional family therapy and have that young person participate. Obviously, Kevin mentioned that the parole officers are reaching out to South Community and developing those plans when they're being released from the Department of Youth Services institutions. And parole has a linkage to South Community, and functional family therapy is available to all of the people that are coming, young people coming out of the Department of Youth Services. One of our biggest success cases back in 2005 was a young lady that was given an early release by her judge who went through the functional family therapy project and was a huge success. Another area is in Montgomery County, we have a open setting residential treatment center called the Nicholas Treatment Center. It's a 24-bed facility just for boys. We've gone as far as to invite South Community into that facility, and we have a contract where they provide a therapist on site at Nicholas, and the planning for going home begins on day one. We also, as part of that contract, utilize psychiatry services, and we do medication management for the young people that are in that open setting residential, and we've been real successful in just transitioning them with their South Community therapist into FFT and the LIFE Project, as well as some of the other services that South Community offers. Another project where we've developed a nice pathway is through what we call our J-Care project, Juvenile Cognitive Alternative Rehabilitation Effort. I think in the juvenile justice world we have more acronyms than we can ever imagine, but there's a good one for you, J-Care. This is an 18-bed program for boys, and they're actually housed securely in our detention center. They typically stay for about 90 days, and while they're there, they're receiving aggressive replacement training. And at the beginning, we're planning for their discharge. South Community, again, becomes involved with family assessment and figuring out if FFT would be a great step-down option for them when they're leaving J-Care. Again, this is a secure environment, and families are involved from the beginning there as well. Another option in Montgomery County is our community correctional facility called the Center for Adolescent Services. This is a facility that houses both boys and girls. And this is another example, just like our open setting residential unit. This is our locked setting that has invited South Community in. They have provided through contract therapists as well as access to the psychiatrist for medication management. And individual and family therapy is taking place alongside of cognitive programs that are happening at CAS. So kids that are leaving CAS will have a plan to enter the LIFE project once they've successfully completed, and they will move on into the community and receive those services from South Community. A big linkage obviously comes from our probation department. In Montgomery County, we have about 950 kids on probation. They're on probation for felonies, misdemeanors, and status offenses. And when we originally did the BHJJ grants, we insisted on having probation officers assigned to the Life Project. We felt that this was a way that we could really be successful by designating a PO to cooperate closely with the South Community Therapist. And I think this was a very wise decision early on because the collaboration, the planning, and the things that go on for the families in their agency as well as being in our agency are amazing. So those 4 POs have all of the kids involved in the LIFE program that are post-adjudicated youth on their caseloads. And it's like they work for one another. We have South Community employees at the court building all the time, and vice versa. Our probation officers are using space in their buildings to accomplish their tasks on a day-to-day basis. So probation is a huge referral source towards that LIFE program. We've also received other grants as the program has grown and matured, and we've began to offer functional family therapy and the LIFE Project to kids that are being diverted through our intervention center. In Montgomery County, we have a really unique assessment and reception center. It's called the Intervention Center. Every case that comes to the attention of our court, either through a secure side of the building brought in by the police department in handcuffs, or brought in from the school as a truancy referral, or even a parent bringing a child down, our intervention center handles those cases 24/7 basis. Those cases are assessed, screened, assessed, and linked to treatments right there in a triage kind of scenario. So we're front-loading those services and not necessarily waiting for the court process to play out to get them linked and involved with treatment. The intervention center is diverting about 2,900 cases each and every year. We also have a really successful program dealing with the disproportionate minority contact issue. Kids that are coming to our attention, we're getting them involved in mediation rather than becoming official or even being handled unofficially in our court. They are handled by a mediator. And one of the options on the mediation agreement is the LIFE Project. So if there is family conflict or family issues, we would have already had an assessment completed through the intervention center, and they are linked at that point to the LIFE Project as well. So those are the multiple pathways that we have established in Montgomery County to get to treatment once the out-of-home placement has taken place, or even if they're in the community already, being the case of probation and the intervention center. I think something that I really want to emphasize, and I'll get to my next slide here that kind of goes through these things, is getting involved as early as possible when that youth is placed outside of the home, either in a secure setting, such as DYS, Department of Youth Services, or in an open setting like our Nicholas facility. The youth are going to be returning home, so we have to come up with a plan for them. And the earlier we get started, the better off we are, because we can anticipate cooperation and a number of other things that were mentioned earlier. So starting early is a big key to our success. We've also been open. We were willing to allow therapists into our facilities. A lot of times courts are very closed and very private organizations, and things that are happening in detention are happening in detention. Our judges, Judge Nick Kuntz and Judge Tony Capizzi, have taken the approach that that's not successful for kids and families. Let's get as much assistance as we can to them, making sure that they're safe and secure, but getting as much assistance as we can to them. And the example of that is contracting with South Community to have a therapist at our Nicholas facility as well as our Cass facility. The last thing I'll talk about that's been such a success for us is collaboration. Again, when we talk about our story with other courts and other treatment providers, they just couldn't imagine the collaboration that we have. And I think it's because we all have very similar goals in helping kids and families, and we'll do what it takes. I talked about our 4 probation officers. They each have cell phones and can communicate with therapists directly on the push-to-talk. So they are communicating what's happening with kids on an up-to-the-minute basis, and they're being a unified team rather than the youth or family trying to play one of us against each other. The administrative staff are also collaborating on a regular basis. We're always looking for other ways to find funding or look for opportunities to help kids and families. So those are our big successes. I think Barb is going to take the ball from here and describe from the agency standpoint how it's worked for us in Montgomery County. So Barb?
Thanks, Eric.
Thank you, Eric.
Go ahead, Barb. You're on.
Okay, thank you. Okay, this is as Eric mentioned, South Community Behavioral Health Care is located in Dayton, Ohio, in Montgomery County. We are a private nonprofit organization, and we are one of 4 major community mental health centers in the Dayton area. Excuse me, I think I'm losing my voice too. We have provided a wide continuum of mental health and alcohol and drug services to adults, youth, and families for over 30 years in the area. When youth are ready to be released from the Ohio Department of Youth Services or from local facilities, our mental health providers will receive a referral from the Montgomery County Juvenile Court, and we usually get those approximately 30 days prior to the discharge to assure mental health and alcohol and drug needs are met and that appropriate service delivery is part of the reentry plan. Meetings are usually arranged with the youth and the family, in which these meetings can take place at the local facilities, at our office, or in the home to assure linkage of services and that we begin the engagement process. A mental health and drug and alcohol assessment is usually conducted at that time with the youth and the family, and as part of the assessment, there is a lot of collaboration with the family members, facility personnel, the probation officers, and the parole officers, and other service providers, and we really see that as imperative in gathering information, developing a comprehensive reentry plan for the youth who are entering back into the community. The reentry plan includes an assessment of the youth and family strengths. We look at risk and protective factors, needs, and barriers to meeting these needs. And as part of the assessment, then treatment recommendations are then made. If a youth has been placed in one of our court's local corrections facilities, South Community does provide the mental health and co-occurring services through the placement of our therapists and psychiatrists in the facilities. And the therapists and psychiatrists work with the local facility staff to make every effort to keep the family engaged in services. We try to invite family members to participate in family counseling sessions and or their medical appointments with the psychiatrist as needed. We keep family members involved, and keeping them involved is really a critical element to assure the youth success. Discharge planning with the family begins with the youth when they enter into the facility, not when they're getting ready to come out. And a large advantage of youth being placed in local facilities here in Montgomery County is the continued connection with the family and the community. Local placement allows us to create comprehensive treatment models and allows us to continue direct collaboration with community partners, which include mentors that may be involved with the kids, the school, and other formal and informal resources that are involved with that youth and family. Local placement also allows for us to be able to build positive relationships with the youth and caregivers or other adults that can be effective in helping youth as they re-enter back into the community. And this helps us to prevent problem behaviors when they are being released. Local placement also allows an easier linkage to other South Community services. Once a youth is released from programs, the youth can remain with their current therapists and psychiatrists when they're transitioned out into our outpatient services. So this assures continuity of care. It helps to streamline the linkage to other community-based services, and it allows for no disruption in services, which is important. We have also seen a higher rate of follow-through with community-based services once youth are out, when they've already had a connection with mental health providers while in the facilities. South Community is able to offer a wide continuum of care of youth re-entering into services when they're coming from the Ohio Department of Youth Services and from local facilities. youth and families can be referred to our LIFE program, and that is our program that utilizes functional family therapy as the evidence-based practice intervention. But we also have other services that include case management services, psychiatric services, outpatient therapy, partial hospitalization, and we do have a primary care program here where we can meet those primary care needs for youth as well. As youth enter back into the community, we think it's important, and it's been mentioned by Eric and also by Kevin, it's important that we make those connections as quickly as possible. And our providers are expected to make contact with youth and families within 48 hours of release from any of the facilities. Within the first 10 to 20 days of release, usually the provider that's involved with the family spends time engaging with the youth and the family into treatment or assuring that immediate needs are met. Although planning is completed prior to release, linkages are already made. This time it's been assuring that the connections have taken place and there's not barriers for the youth and family in accessing resources to meet their needs. Some of these immediate needs that we see with the youth are things like re-enrollment with school, permanent housing options if the youth is not able to return home, and preparation for employment, medication refills if they're coming out of the facility on medications, and their primary medical care needs are sometimes needing to be met immediately. Once the youth and family are engaged, the providers will work on maintaining changes in behavior that have already been made while the youth has been in the facility, and part of that reentry plan or part of that plan is really working on strengthening positive relationships with family members, or reducing any negative behaviors that increase the youth's risk then for relapse back into the facilities. Communication and collaboration is very crucial, and Eric mentioned this, but with probation officers and parole officers, it's crucial at every stage of the treatment. And meetings are scheduled with the therapist, the probation and parole officers, the case managers, and the psychiatrist weekly to assure appropriate continuity of care. In between meetings, we do have a lot of contact by phone, and the probation officers and the parole officers actually even go out with some of our staff to do home visits together and meet with the youth and family together to ensure involvement and ongoing engagement. All providers and core personnel approach youth and families with the strengths-based interventions, and all our LIFE program probation officers have also been trained in functional family therapy along with our home-based therapy staff. And this, what we've seen is this has really helped to assure that core personnel and mental health providers are working together and they're not working in separate directions when intervening with youth and families. Our collaboration takes place with, other collaboration that takes place are with natural helpers through Reclaiming Futures, child welfare, the schools, the Ohio Department of Job and Family Services, and any other systems that may be involved with the youth and family. We also require heavy collaboration with functional family therapy as part of our LIFE program to assure fidelity of the functional family therapy model. And we have high collaboration with Case Western University at the Begun Center for Violence Prevention Research and Education as part of our LIFE program, and they also evaluate our program data. And what we found is the data has really shown to be an important element in our program success. A lot of courts have apprehensiveness, I think, sometimes to collect data on youth or adults even in certain programs. But it really has helped us to evaluate our program. It's led us to help with sustainability of funding. It's helped us to look at program expansion in areas we can expand, and really to be able to better address the youth and family needs, as well as it's helped us to prove cost effectiveness for our community. So youth who receive services in our LIFE program, we have shown significant improvement. 2/3 of the youth who completed community-based programming reported a 61% decrease in contacts with police. There's been a reported use of a decrease in alcohol, marijuana, and cocaine use, and that's been cut tremendously. Trauma symptoms, including anxiety, depression, anger, were all significantly decreased. And functioning in the home, as reported by both the youth and the parents, also significantly improved. And aside from increasing the overall functioning in the family and decreasing symptom severity, our community-based program, the LIFE program, has also reduced recidivism rates for the youth. For youth involved in juvenile justice, juvenile courts, depending on the literature reviews, they've shown a decrease anywhere from 15 to 45% reduction in recidivism from what we've seen. For youth who have successfully completed our program, we've shown a recidivism reduction of 69%. So, and also with kids that have been through the LIFE program, we've seen only 1% of those youth end up in the Department of Youth Services custody. So it's a huge success for our program that we're keeping kids locally, we're keeping kids into the community, so that they're not ending up at Department of Youth Services at some point in time. So, we've constant collaboration between the juvenile justice systems and mental health, utilization of evidence-based practice models, successful linkage to service prior to reentry into the community, and ongoing engagement with the family have really been our keys to success for the youth and families in our community. And that's it.
Thanks, Barb. Appreciate it very much.
Thank you.
Okay, so we've got a question sheet up now. So those of you who have not yet asked your questions, please do so now. I do have a number of questions that have come forward, so I'm going to start entertaining those first. They came in during the course of the presentation. The first one, really, I think, Kevin, is best for you. And it is, okay, how did you work with your facility staff and your field staff in making sure they would work well as a team? Normally, in our jurisdiction, we find these to be two very separate worlds.
Well, quite honestly, we have experienced that same two separate worlds historical perspective. But I was able to go to the folks who work in our facilities and present this and demonstrate the benefits to the youth, not only in the facilities, but upon release and even beyond parole. And with a couple meetings and a couple conversations, I think, there was some give and take. For example, we agreed that we would not do video communication in pieces while the youth was in school. Obviously, we didn't want to pull youth out of his education during the day. So, we were able to sit down and figure it out relatively easy. It wasn't as difficult as you would think.
Okay. And you found that the facility staff over time were welcoming to the JPOs, either being on site or through the video communication capacity?
Yes, and it's been a process. Obviously, it's a huge change for not only the facility staff, but for our parole staff and everyone involved. But by and large, we have been able to make the adjustment, and in the effort to do what's best for the youth, we have made it work.
Okay, great. This is a follow-up question that I think actually was very much targeted for you. What is the exact role of the juvenile parole officer in that interdisciplinary treatment team? I think on one of your slides, Kevin, you mentioned about the team. I think there's questions about, we want to know what the role is of the JPO in that team.
The parole officer is just one more attendee at that group. Typically, the youth social worker facilitates the meeting, and as I mentioned, all disciplines are represented. So we'll have someone from the mental health side of things, we'll have someone from education, we'll have someone from maybe physical education or rec or something like that. And so we have a number of folks representing all the disciplines. The parole officer is there, and his or her input is typically where we are working with the family, what's going on with the court. There may be an example of the court is considering an early release or something like that. We may have some input, for example, from someone like Barb Marsh, who, if we know the kid's going back to that agency, we'll say, look, we've already made contact, we will have an appointment upon release. And so I guess in short term, they are a participant, but they're bringing a lot of information to the table.
Great, great. That is a great segue, Kevin, into the question that was posed, I think, that really falls into Eric and Barbara. So, Barb, the question pertains to whether, when you mentioned about the ability if a child is locally placed into a facility or residential treatment center, that you're able to make contact with them more readily. This question is, have you been able to make contact and visit youth who will come onto your caseload that are in DYS facilities?
We have not been able to visit the youth while they're in the DYS facilities, and mainly because of the distance from Dayton to some of the facilities. It's a lot easier for us to be able to continue continuity of care for the kids while they're local rather than placing them in DYS. But, you know, we work very closely with Kevin's parole officers and work towards and do what we can to assist in reentry back to the community with the barrier of the distance of the youth from Dayton.
Okay. So I have my own follow-up question then. So do you make contact by Skype or by phone? Do you have any contact with youth at all before they release from a DYS facility?
No, we typically don't have contact with the youth. We have a lot of contact with the parole officers, usually within 30 days. So we gather a lot of information, and the parole officers actually bring them to their first session many times with the family. So we're able to make that connection and that link and that handoff to our services right when they're released.
Okay, great. Thanks, Barbara. This question is really, I think, geared, at least initially, for you, Darren. Anyone else should jump in on this if they have an answer as well. But the question basically was that you noted a lot of parental resistance that can be present, sometimes parental anger. Do you have any suggested approaches to best deal with the kind of parental engagement that you're advocating? And I think, Darren, this question came in shortly after your slide on family involvement pre-transition, transition, and post-reentry. And you're looking for any tools or any approaches you think are most successful in getting to this point.
Yes, in fact, we have attempted really to be very specific in creating a document and portions of that. I would be happy to share. My email address is listed there. But the document essentially outlines current family response to treatment and corresponding engagement strategies. So under the heading of intense conflict and negativity between parents and youth, we then have strategies outlined for that, clear identification of clients' 1-year and 5-year and 10-year goals, brief therapy questions such as asking parents why they haven't thrown in the towel at this point have been very productive. Getting families to be very clear about, sometimes this comes under the heading of the miracle question, for example. If a miracle were to occur and all these problems went away, what would be different in your home? And families will then be very specific about what it is they're really looking for, which helps us focus more instead of chasing different problems and reframing problems to make them relational. Under the heading of guarded and resistant, there are a series of interventions that we ask clinicians to use. Passive response to behavior problems. We tend to use motivational interviewing techniques. Uncovering the crisis that may be really behind some of the youth's behavior in front of the parents. So those are, again, just kind of a shotgun approach to sharing with you some of the ideas there. I would be happy to share this document with you, but matching the intervention to the parent's initial response to treatment we found has been really productive in engaging those families over the long term.
Great, great. There was a separate question that wasn't directly related to this one, but I wanted to pose, and that is about the use of parent coaches or parent mentors who have been through the system before that might help parents who are being asked to assume these roles upon release of the child. Does anybody on the call have access to information about the use of parent coaches or parent mentors who have been through the process that might be able to help other parents who are now just going through it for the first time?
Shay, this is Eric. We don't have specific parent mentors that have experienced that themselves that are available to link to families that are having someone be released. We do have a parent advisory group that has actually 3 parents that are in that situation that advise, and we've done parent training and tool shops and things like that, but we don't have enough parents to actually link one-on-one mentors.
Okay, thanks. Anybody else? I know there's an organization, Federation for Families, that may also be available in local communities, local chapters, that can be helpful in that area as well. This question comes back to you, Kevin. It's about the use of the family finding technology. As I understand that, and I'm going to paraphrase the question here, as I understand it, that's a way of finding additional family members that may have not been known to the agency. Who determines which of those family members are appropriate in terms of their being supportive of the treatment plan? How is that due diligence done for that use of that technology?
The way we have handled it is that our parole supervisors in our offices have kind of directed this initiative. However, what they do is once the internet searches run and we may get as many as 30 or 40 persons identified, we will begin the process of following up with them, and we go out and we'll send our parole officer out to meet with as many of those folks as possible, and the parole officer will actually do some assessment work and work back and forth with the supervisor. They'll set up team meetings either in the home or sometimes back in the office to gauge the appropriateness of this person being reintroduced into the youth life. So it's kind of a team approach, but it is something that we do take the time to do, as we could all come up with reasons why we wouldn't want particular people back in the youth life.
Okay. And does this technology just find the family members who have been known to the youth, or does it do an expansive search that may actually find family members that have become distant that might be positive influences?
No, it could be, it's run based on Social Security number and information like that. So it could be, and most often it is individuals who are not known to the youth, or they may be distant relatives. I gave the example of the 3 particular youth we've now dealt with where the youth was entered into the child welfare system at a very young age, and we have, for whatever reason, information was given to him that his parents had passed away, and we have identified and found living parents who were separated and had not had contact with their child for 12, 15 years, and then got them back together. And it's been, and I'm not going to tell you they've all been positive, but by and large, 2 of the 3 were extremely positive. One was kind of hit and miss. But for the youth to go and tell them that you have a mother who's alive is extremely enlightening and even something you got to pay attention to. We need to have mental health staff there on site and be there to be able to work this through with the youth. So it brings a lot of different aspects into the picture, but worthwhile in the end.
I think one of the interesting pieces about this, and I'm looking back on the slide that Darren had up about the family role, is that what you're in essence doing with this family finding technology and the juvenile relational inquiry tool that you described is finding other supportive people who can be supportive of the treatment that the child needs. So very particularly, not just in general success for reentry, but very particularly on behavioral health needs, those youth need support systems that gear them towards success and avoiding, and we know we're going to have relapse, but avoiding too significant a relapse where the child spins into a negative way. And so finding those additional individuals, however it's done, is a very important technique, and I think you've probably enlightened a lot of people today about using that kind of technology, which I understand does come from child welfare. I have another question here, and I think it is a general question, and it is, are there unique issues in working with girls around behavioral health issues? And if so, how did you address them? I'm going to start with Barbara. If you want to take that on first around the gender issue, and anyone else who wants to jump in, I'll turn to Darren as well.
Okay, well, with the LIFE program, we started the program with female offenders who were violent coming out of the juvenile justice system. There were certainly unique needs around, at least for when I speak on the therapeutically, there were a lot of unique needs around trauma-related issues with girls, more so than we see with boys. So I think the trauma issues were the biggest pieces that we saw with the girls, and being able to work with that in a family context.
Okay. Darren, you want to jump in as well?
Yes. So I think Barbara has really, noted well that there needs to be an effective response related to the trauma issues that do seem to be a bit more pronounced there for girls. But I would also say that the family relational issues are definitely a necessary target for most of the young women that we're working with. Concerted effort there to strengthen the family situation between mothers and daughters and others who are involved. We've tried to recognize that there seems to be heightened impulsivity issues early on for the girls who are in our program, and trying to intensify services a little bit more for them to just keep them in the program early so that they can receive the extended benefits over time. And then lastly, one of the things that we've done, we also use the model aggression replacement training, but we have modified that to meet more of the relational and trauma issues that are associated with that. It's still 3 times a week. It still uses the same elements of ART, of skills training and more reasoning. Anger control training is expanded to include more emotions than anger, and it's called girls self-efficacy training. And we have seen some great results by using that model. It's manualized for both the facilitator and also for the girls, so that they have their own workbook to use during the 30-session intervention, and we found some great success there. And we've measured the reductions for those girls in their psychiatric symptoms, their substance use symptoms, social competence, family, educational, and we can share that data showing that these girls are making dramatic improvement as they participate in the girls self-efficacy model.
Great. Thank you both. Here's a question about the court's involvement. What are the best strategies to keep judges and the courts involved in these cases? And I'll just make a side note. When we did the first webinar, we had presentation on the court staying involved while the youth was in the facility getting treatment, monitoring or helping to monitor the use of medication, and to determine whether the child had come into the facility on medication, whether medication was continued or not, and then whether the youth was not coming into the facility on medication, whether medication had been ordered, and trying to gauge whether we were potentially over-medicating or under-medicating young people in treatment in our facilities. This question is about keeping courts or getting courts involved in the reentry process, and whether that might be advisable, and if so, what are some of the strategies to get them involved? So anyone who wants to jump in on this one?
Well, this is Eric. I can jump in, Shay.
Thank you.
I think getting the courts in. I think in Ohio we're very unique. A lot of folks on the call are probably familiar with Reclaim Ohio, which has incentivized keeping kids at home and watching how many days youth are at the Department of Youth Services. So in Ohio, judges are interested in that from the get-go because it's incentivized. There's funding tied to it. But outside of that, I think it's important that the judge be involved, because I think the kid pays a lot more attention when they feel that they're accountable back to the judge and they have to go back to them. Each of our facilities has a reentry hearing that takes place. So if you go to our CAS facility, when it's time to go home or you've been working on going home and it's time, the plan is solidified, sometimes with court orders, with the judge, in front of the judge. So I think the original question, Shay, was how do you keep judges involved in that? I think that probation staff and court staff can talk to their judiciary about the importance of hammering home some of those orders so that kids will comply with what's going on when it's time to get out, either going to a life project or getting a job or whatever that may be as part of their reentry plan. It just helps so much if the judge can be involved. So trying to talk them into that from the beginning by showing maybe some data or some other ways that it's been successful is an approach that you could take.
Thank you, Eric. Any other thoughts about this idea of involving courts and how to best involve courts in the reentry process, but in particular around the treatment issues?
Yeah, this is Kevin, and I can tell you that our parole officers, part of what they do is trying as best they can to keep the judges and the courts up to date on ongoing progress while the youth is in the facility. We provide reports for them. We find that, across the spectrum, we have courts, we have large courts like Cuyahoga County, which is Cleveland, and we have small courts. Typically, we have much more a higher rate of success in the small counties for a lot of reasons, but including that they may only commit a couple kids a year, and so the numbers aren't so vast. But our parole officers are in and out of those courts on a weekly basis, so they're able to, simply just establish the relationship and keep them up to date. Now, the bigger courts, where you have, you may have 7 judges in one court, it gets to be a little bit more of an undertaking. But as I say that, Summit County, Akron, Ohio, is probably one of the better examples that we have. Judge Teodosio up there, she actually does status reviews for every youth committed from Summit County about every 6 weeks. So she'll be on the bench and do a video review with every kid who's in our facility, and the parole officers are right there in the courtroom, and it's a powerful message for the youth, I believe.
Great. So I think we're almost out of time. So I have one last question that I want to ask, and it kind of ties into this court question, but it deals with, and Darren, I think this comes back to your slide on prepare and plan for resurgence of symptoms and relapse. When we're talking about having more parole officers or reentry aftercare workers working with treatment providers, has it been a challenge to align the thinking that there is going to be relapse and that we should be avoiding technical violations? Has that had to be a reorientation for Eric, probation officers in Montgomery County, Kevin, for your parole officers in Ohio more broadly, and Darren, your experiences in Utah, has there been a challenge around getting workers to understand that there can be a relapse and it shouldn't lead to a technical violation?
Well, I'll jump in then, and the other two you've identified can share their thoughts too. Absolutely, it's been a challenge to get judges and probation officers to recognize this and see this resurgence and relapse as part of the norm in working on behavioral health challenges. I think we've made substantial progress with informing judges and probation officers about this issue and coming up with alternatives to simply filing a technical violation or issuing especially other sanctions that pull them away from the very treatment that they need. And that's been the problem, is that the youth's engaged in treatment, they're participating, but they're experiencing a resurgence in the symptoms, and they're pulled out of the very treatment that will help reduce that over time. One strategy has simply been to help judges and probation officers see the average number of sessions that have occurred for those individuals who are successful, and then to help them see that these youth who are not being successful are being pulled out before they hit that frequency or that dosage of sessions that's needed. And that's one strategy we
strategy. Kevin, Eric, real quick. We have about 1 minute left.
This is Kevin, and real quick, yes, we have had a tremendous shift in our view of a parole violation. I believe we file many fewer parole violations and we address them differently in the court. We try to come up with other diversions rather than sending them right back to the court. And the courts, in turn, have worked with us to create other sanctions rather than return to DYS.
Great.
And I'll just say real fast, Shay. I think Kevin mentioned it during his presentation. I think training probation and parole officers to be change agents and not police officers helps us get around that idea, using strengths-based practice, teaching them motivational interviewing themselves, ethics, like Kevin mentioned, begins to change that mindset towards helping treatment rather than seeing how many arrests you can make.
Excellent. Okay, I'm going to kick it back over to Nastasia to close out, and I want to personally thank you all for the work you did in preparing for the webinar and the outstanding material that you provided. Thank you. Nastasia?
Yep. Thank you, Shay. Darren, Kevin, Eric, Barbara, thank you so much for doing this webinar. It was really informative. This concludes today's webinar. After you exit the webinar, a brief survey will appear on the screen. By answering these questions in the survey, you'll be helping the Resource Center improve on the services that we offer. We greatly appreciate it if you would take just a few minutes to complete the survey. We will email a link to the recording of the presentation, as well as the link to the PDF of the PowerPoint slides used in the presentation to all participants early next week. These links will also be made available on the National Reentry Resource Center's website, csgjusticecenter.org/NRRC. Thank you and have a great day.